So many thanks for everybody who's present, for Angelica, who is responsible for the link now. And today we have quite a few cases of adenomas for which Laurence Chiche is a well-known expert. So Laurence, if you don't mind, I will let you to moderate the session, and
Okay.
we can start at least with one of the cases from Lugano. We have a mainly feminine representation, but we are four of our students here to present the cases. So, Eleonora, would you like to start with your first case?
Yes, maybe Isabella can start because she's
Isabella,
at
you
work.
start with your case.
Yes, thank you.
Up
So
to
I
you.
share the screen. Yes. Can you see the screen?
Yes,
We do.
Okay.
yes. It's still in preparation mode or presentation mode. Yeah, perfect.
Okay. Okay. So good afternoon to everyone. We have the case. Oh, sorry. Yeah. Of a young lady of 40 years old with slightly overweight, with a BMI around 27 and with hypercholesterolemia. She had a myocarditis the last year with an eventful recovery, and she did a follow-up cardiac MRI where we found a nodular struma of the thyroid. So she underwent other investigation and finally a thyroidectomy. At the same time, the same cardiac MRI, we suspected also FNH and multiple adenomatosis. So we perform few months later a liver MRI, finding a large adenoma of S4 and S8, multiple little adenomas, and FNH and EPM and main duct of the branch duct, sorry, of the pancreas. I can show you the MRI. So here the main adenoma. And the other. So we suggested to the lady to underwent resection, at least of the larger adenoma, but she refused. At the time, she was under anticonceptional pill, so we pleased her to stop. And we keep on with the follow-up MRI after 6 months, showing a stable EPMM and a reduction of the main adenoma and some of the others. So this is the last MRI. Still here the main, but little bit smaller. So now we were wondering what to do because she's still not very keen on going on with surgery. Maybe we can suggest a weight loss surgery or just a follow-up again with an MRI in 6 months, or do you have some other suggestions? Thank you. That was the case.
Okay. So do you know what
maybe a couple of more items to add to Isabella's presentation. Not all the adenomas have fat in them. In fact, just only one of the adenoma has fat in them on MRI. And she has a slightly raised CRP, C-reactive protein, at around 33.
Okay.
Okay. Do you know, because now, today, when we speak about adenomas, we have to indicate the type of the adenoma. So it's impossible to define this type on this MRI, on these only sequences, but probably it's inflammatory adenomas. Is it right?
Why you say that? Why you say that? Probably inflammatory.
Because the main one seems to be with some area of hemorrhage.
Can you show that?
But we need to have an MRI with special enhanced with a hepatobiliary specific like Primovist or multi-hands.
That she has that. She has had that.
Okay.
Laurence.
So you know that there is
typifying the adenomas with that.
Okay, but is it inflammatory adenomas? You said that some of adenomas have fat in them. This is particularly, this is adenomas of HNF alpha mutated adenomas. So those one are not very dangerous, very low risk of hemorrhage, low risk of malignant transformation. In case of inflammatory adenomas, you have to be sure that it is not mutated beta-catenin, okay? And this is why in the case of inflammatory adenomas, you need to have a biopsy if you want to follow or have surgery. But you know that the recommendation today is to operate, to do anything when the adenoma is more than 5 centimeters. This is the rule of the size. But in your patient, you did well because you stopped the estrogen therapy. Am I right? And the adenomas reduced. Okay? So inflammatory adenomas are associated with estrogen therapy and with overweight. So she has probably this type of adenomas, and particularly because again the main adenoma is not completely homogeneous. There is a center with hemorrhage, but well, I suppose because I have not enough sequences to say that. So the fact is that first, there is no indication for resection because the adenoma is much less than 5 centimeters and reduced after stopping the estrogen therapy. Second, I don't know in Switzerland, but 26 of BMI is not an indication for surgery of bariatric surgery, is not. So she has to do some diet, of course, but she is not really obese. She's just overweight. So you can't say that you have to bring her to surgery. That is impossible. So, to my opinion, this lady should be just follow up.
Yeah. Laurence,
in the US, BMI of 26 would be considered a complete success after bariatric surgery.
Exactly. Exactly. This is good.
Yeah. Laurence, just a few more items and questions. One of the adenomas is in fact larger than 5 centimeters. The big one is larger than 5 centimeters.
She said 48 centimeters.
No, I think times 6, wasn't it? What is the largest? I thought it was larger than that. Anyway, we'll remeasure it. What do you think of the CRP?
The CRP is associated with inflammatory adenomas. This is one of a clue for the diagnosis, of course. But if you have a good radiologist, he has to know when it is HNF alpha mutated or inflammatory, because you have, at the portal phase, you have a atoll sign, which is possible in, well, 40% of these inflammatory adenomas. This is pathognomonic. So you can diagnose those type of adenomas only with MRI. But you know that 10% of these inflammatory adenomas are mutated, beta-catenin mutated, and particularly with exon 3, which is quite worrisome because it can first, well, it can have a malignant transformation. So in some other, you have a mutation in the exon 7 and 8, and it's possible to have a higher risk of hemorrhage. So this is interesting. When you have an inflammatory adenoma, you have to follow up and just to know if it's mutated or not. If it's not mutated, there is not a lot of risk to just follow up. But if it's mutated, well, you have to convince the patient to do something.
Yeah. Should we do a biopsy then? I think we should.
I think that it would be interesting to have the biopsy to just subtype the adenoma concerning the mutation of beta-catenin, yes. But it's rare.
Right.
Julia,
Thank you very much. Can you develop about the radiological MRI sign of inflammatory? Because I knew that the fat infiltration is typical of HNF1 mutation, but the inflammatory, I saw the publication of yours preparing for this session that you can, some hedgehog have a rare radiological sign of a vesicle in them.
Yes,
But
exactly.
for inflammatory ones, I was still dithering.
Yes, this is quite new for the Sonny hedgehog. Sonny hedgehog are very, very rare adenomas, but in my group, they are completely excited with this type of adenomas because they have a particular risk of hemorrhage even when they're small. So this is quite interesting, but so rare. But inflammatory adenoma are much more frequent, and particularly in overweight and obese patient. And they respond to the discontinuation of estroprogestative therapy. So this is very important to have this classification. And you, as I said before, some of those inflammatory are mutated with beta-catenin. But concerning the MRI, in fact, those typical adenomas have a special enhancement at the arterial phase. And at the end, you have this surrounding that is called a tall sign. And those inflammatory adenomas are hypervascularized, very few fat in it. It's very rare to have fat in it. Necrosis, some areas of necrosis. And it's, it's exactly what they called before telegentative, because of there is those arterial, they are arterialized.
Good, thank you. And do inflammatory adenoma respond to GLP-1 agonists, which are now trendy? I tried to look in the literature whether we should associate those for patients with insulin resistance to where they come, whether they shrink by treating the insulin resistance with Wegovy or what. Can you develop on that?
Well, these GLP-1 agonists are really stars now. They are curing everything. But for the moment, we have just a special randomized essay about JAK2 agonist, in fact, for adenomas, inflammatory adenomas. But to my knowledge, there is no essay, no trial about GLP-1 agonist. But I suppose that since we have some report about regression of adenomas after bariatric surgery, I think that, of course, anything that can cure obesity will be good for adenomas. Losing weight, GLP-1 or not, and bariatric surgery, if it's indicated, of course. I think that this is one way to cure adenomas, and particularly multiple adenomas.
Sorry.
One thing about GLP-1, I'm sorry, Monsieur, you want to say something?
No. Laurent?
Yes, Dimitri. Dimitri, you
you
want to
said-
say something?
Yes. What I wanted to say is that, well, right now, in New York, everyone's on GLP-1, just about everyone. It's ridiculous.
You take one?
Really.
You take a GLP-1 yourself?
No. I actually I chose exercise lately, so we'll see what happens.
Great.
Not there yet, but the point is, what I was trying to make is that a lot of people are on it, and insurance companies are approving it kind of slowly. So a lot of people paying out of pocket, and it's very expensive. But so the point is that a lot of people start on it, they lose a lot of weight, and then they don't want to pay $2,000-3,000 for this a month, and they drop. And when they drop off the medication, they instantly regain the weight and plus 15 to 20% more than what they had before. So the question is, and it's interesting to me, if we can cure adenomas with this, if we can cure adenomas with this GLP-1, and if we stop the GLP-1 and the person regains the weight, would the adenomas return or increase in size again? That's a question that I have.
Yes, probably, but GLP-1 in France is like United States, a very expensive, very, very expensive treatment. And we know now, as you said, that you have to continue the treatment in the future if you don't want to regain your weight, and it's very expensive. In France, it is reimbursed if you have diabetes and just for one type of GLP-1 agonist. So of course it's not the problem here. I think that lose weight, bariatric surgery is okay. GLP, and we have no data to say that. I think that Dr. Christodi want to say something. She rose her hand. Yeah.
Yes, thank you. I had a question about very low dose pills and only progestinic pills. Like we had a specific case of a very young woman who had interrupted the anti-conceptional pill, and her adenoma decreased to 1 centimeter. We don't know the histology of that. But actually, she's now asking if she can have a mini dose pill or a only progestinic pill.
In fact, if the adenoma respond to estrogen, as you said, it is preferable not to have estrogen at all. So progesterone or any other device without estrogen would be better for her. Yeah.
How to do to raise the hand, Laurence?
You have, I'm sorry, but you are, I'm sorry. You want to say something? You have your raised
I
your
tried.
hand raised.
Okay, no. You said. I think you said that inflammatory adenoma was mainly linked to the pill. You said that? No,
No,
or
not
not?
mainly, but those type of adenomas are associated with estrogen. And if you stop estrogen therapy, sometime they reduce. or these type of adenoma can bleed during pregnancy, for example, or so it is related to estrogen. Yes.
But we are seeing now many adenoma linked to estrogen. The pill is not modified now.
Yes, it is. You're right. Now we have very low dose, but still, the recommendation now is to stop any type of pill when you have those type of adenomas. Try to see if stopping the estrogen cause the reduction of the adenomas. But today, the major cause of adenoma is obesity.
Huh? But you know, as you said, she's 26, BMI is 26. You consider this is obesity. I have
No,
25.5. I have to do, I
26.
have to have surgery.
That's why I said that surgery is not at all on the table, because 26 is not at all obesity. It's quite normal. It's
26, 26 is
that's
quite
exactly what
normal.
said Dimitri.
No, for
Dimitri said that.
this poor lady, 26, you see, obese and to have surgery for obesity.
No, no,
No, of
it
course.
was
Oh,
it
wow.
was it was just to throw concepts that obesity surgery, even in non-obese patient, can treat diabetes and can probably treat adenomas.
Oh, no, it's
We don't do obesity surgery in type 2 diabetes, and probably we should. But it's too early for that.
yes, I think so.
I have another question. When you say surgery, if it is indicated, of course, is not the case, can you think also to local destruction by
No,
radiofrequency? The contraindication for hepatocellular carcinoma, for instance, is that there are some foci outside of the tumor, but this is not the case here. But benign tumor is the best indication for local destruction. But
but
what is against this
why
idea?
the problem is, why do you treat a benign tumor? Why?
Well,
Whatever the treatment.
the risk of complication. You spoke
Okay,
about bleeding. You spoke about bleeding.
okay. The risk of bleeding of a 3 centimeters adenoma, maybe HNF, or is very, very low and probably lower than the risk of any treatment. That means that you have not to think about distracting all the adenomas in a polyadenomatosis. You have to see what is the risk of this patient. And the risk is very low. The risk of malignant transformation is less than 5%. 5%. And it depends on the type of adenoma. If you have an HNF alpha, if it's less than 5 centimeters, the risk of hemorrhage is near zero. So if you have a big adenoma, whatever the classification, whatever the subtype, there is a risk of malignant transformation and much more of bleeding. So you have to treat them. But if it's less, if it's small adenomas, you have to just, well, despise them.
But in the case of
But
this
follow up.
patient, in the case of the patient with inflammatory adenoma, you said that the risk of degeneration is very small.
Yes, it is. But the bigger one, which has some hemorrhage areas, is not completely safe. I agree with that. But
But
it reduces.
you recommend a biopsy. Why not to do a biopsy to see if really it is inflammatory
Yes, it
or this
is.
is not? Hmm?
The problem that this one is probably inflammatory. MRI can say that with 100% of specificity with MRI. But you have to see if it's mutated, beta-catenin mutated. And if it's beta-catenin mutated, and particularly in exon 3, the risk of malignant transformation exists. But with a good radiologist, the risk of the malignant transformation can be also suspected on MRI, suspected, and particularly if there is a portal washout. I
And
don't know.
this cannot be shown by a biopsy?
It can, but as you say, as you know, the malignant transformation is very difficult to be sure of, because in the adenoma there is area of malignant transformation and area of adenomas. So you have to do the biopsy on the specific area, which is quite doubtful or suspicious. But it's true that if it's beta-catenin mutated, the surgery is indicated. Or the treatment, it can be a radiofrequency.
Right.
Okay? Can
Thank
we
you
see
very
that?
much.
Maybe
Shall
we
we
can
go
see
to-
a second observation, second case.
Sorry, Laurence, it's Valerio. I don't find where to raise the hand, sorry. I've just a question for a long-term follow-up of polyadenomatosis patients. How long do you follow them up? I have a couple of women with polyadenomatosis, asymptomatic polyadenomatosis with very variable size of adenomas, and I follow them up since 10 years. Should we follow them up lifelong? And what you do, for example, for those where you operated a complicated adenoma and they have residual adenomas, how do you follow them up, and what you do for the pill? So I understood that pill, you never tell them to take again the pill, anticonceptional pill. So how long do you follow them up, and how?
Okay. If you have an HNF alpha, which is the most frequent case, because it's steatotic, I just follow them once a year. And if it's stable, I stop and I just make more interval. So if it's absolutely stable, 1-2 years, you can do 2 years, then 5 years, and you stop when the women have a 50-year-old, for example. Okay,
Okay.
at the
Yes.
menopause is stop. Okay. But
Okay.
if it's inflammatory adenomas, well, you have to follow them a little more, uh, more specifically, once a year, or it depends on the course of the disease. If you have some progressive one, which is really rare, 20% of these adenomatosis are progressive. So it's not the main situation. So if it's progressive, you have to follow them a little more frequently.
Intensively. Yeah.
But well, once a year, it's really, really enough. And if you see
Okay.
that it's regress or it's stable, you can prolong the interval and stop at 50.
Okay. Great. Thank you. And for those that you operated for adenomas, you take out one or two adenomas. Do you follow them up, and can they take again if they don't have any residual adenoma? Can they take the pills again afterwards?
Well, in fact, if you read the recommendation, it's the answer is stop for every time. But you can have pregnancy with adenomatosis. You can take pills now with progesterone or mini pills. The only things to do is to follow them and see if the adenoma are growing under these pills. If they
Yeah.
don't, you can give that. It's sometimes it's better to have pills instead of a pregnancy. Well, I think that we have not to forbid either pills or pregnancy in some patient with very mild adenomatosis, small adenomas. Well, 1 centimeter, 2 centimeters, 3 centimeters, you can try, follow, and then stop if it's growing or continue if it's not. Particularly in the HNF alpha, which again is the major situation in those adenomatosis. Okay?
Sorry.
Good.
Sorry, I had no connection anymore, so I didn't hear your answer, but doesn't matter. I will listen it again on the website.
Okay. Okay, any another case report?
Yes, maybe I can present our second case.
Okay.
Just a second. Okay, do you see it?
Yeah.
Okay,
Good.
perfect. Good afternoon, everyone. This is the case of another young female, obese, with a BMI of 37. She had 2 previous pregnancies, uneventful pregnancies, and she's on a therapy with a contraceptive pill, with occasional alcohol intake, with a past medical history of hypothyroidism. She presented to the emergency room for general malaise and abdominal dull pain. The colleagues found mild transaminase increase and hemoglobin of 10.5 in a hemodynamically stable patient with a slight elevated CRP. At the EFAST, they found free fluid in the 4 quadrants of the abdomen and an heterogeneous aspect of the right liver. So they went for a CT scan. Okay. That showed this massive hemoperitoneum, this heterogeneous lesion of the right liver without active bleeding. Her hemoglobin dropped to 85 in 2 hours and a half, so she was referred to the intensive care unit for monitoring. She was stable, so she was referred to the ward the day after, and we performed serial CT scan and hemoglobin checks. We needed to transfuse her with 2 red blood cells. And this is the CT scan we performed 3 days after the presentation with a slight reduction of the hemoperitoneum and the appearance of a reactive right pleural effusion. Sorry. Okay. We finally performed an hepatic MRI with liver-specific contrast, in which our radiologist didn't find suspected underlying malignancies, but she found an intracapsular hematoma and multiple suspected adenomas. The bigger one was like 16 centimeters. And we have another one. And we performed right thoracentesis with a drainage of 1.5 liters of clear liquid that was exuded without malignant cells. So our question is if we have to perform a biopsy of the healthy liver to see if there is any hepatopathy underlying, and how to treat the big lesion and the hematoma.
Okay, thank you.
And I would add one question here, Laurence. When the surgery for this patient, the timing of the surgery, because I saw that in your series, you operated them after 3 months.
Yeah, right. Okay, this patient has a very large subcapsular hematoma, and fortunately, she was resuscitated and she is well now. She's stabilized. So you have this subcapsular probably because of the bleeding of an hematoma in the right liver, and a second one, which is in segment 6, which is uncomplicated now. And so the point first for the first question, this patient has a normal liver, maybe steatotic liver, but anyway, for me, there is no use of a biopsy of the healthy liver. That is not necessary. The second point is that you have to wait because there is a subcapsular hematoma and it will regress. It will be very, in 3 months, it will be very small. So it will be easier for the surgery. The second point is that you have not to do some PVE. It's not necessary. She has a beautiful left liver. And probably after the 3 months or maybe 4 or 6 months, it will be easier. The only thing that may be discussed is not a portal embolization, but an arterial embolization, and particularly for the adenoma of segment 6, because this adenoma can bleed. And if it bleeds, it is worrisome because it will be not a subcapsular, but an hemoperitoneum. So I recommend to embolize this adenoma and to wait quietly until the subcapsular hematoma regress, and then you can operate and maybe do less than a right hepatectomy.
Laurence, for me, it was sure since the beginning that there was indication for an arterial embolization in order
Yes.
to wait without anxiety. Of sure, this kind of large adenoma must be operated, but as you said, better to wait. And the best way to wait is to do an embolization for the bleeding, for the bleeding, and for the other adenoma.
The point to answer this remark, I understand that, but today, when you go to the radiologist and they say there is not some active bleeding, there is no use of embolization. That's what they say. I think it's the rule, but I think that you're right. For me, I would have done an embolization, and particularly of the non-bleeding one, and to see if there is a bleeding on the arteriography. So you can wait quietly the resorption of the subcapsular adenoma. I think that the only contraindication, because I saw that, and you have to be aware of that, the only contraindication to this preventive embolization is an adenoma or a subcapsular hematoma that compress the portal branch. And you have to be aware of that, because if it compresses the portal branch and you do a non-selective or, well, not hyperselective embolization, you can have a necrosis of the liver. So you have to be aware of that. But I think that the embolization was useful here for the adenoma of segment 6, which is big, and maybe the other adenoma causing this hemorrhage. So now I think if you want to wait quietly, I would do that before and then do the surgery in 3 or 4 months. Yes, Pietro?
No, Laurence, what I would like to say is about the risk of necrosis with mobilization. What I know, perhaps it changed, that the embolization stop only in the tumoral part and not in the parenchyma. That means arterial embolization is embolization only for the abnormal part of the liver, not for the normal parenchyma. So the risk of portal compression, I understand for the portal compression, you are right. But you think there is a risk of, if you have portal compression, to have this?
I saw that recently in a patient with a portal a compression of the subcapsular adenoma and an embolization of not the right branch, but the artery of segment 8 and 5, which was the location of the adenoma in segment 8, and she had necrosis of this part of the liver. Yes, it's possible. It depends on the quality of the embolization. The embolization should be very selective, and this risk is near zero if it's hyperselective. But if it's not hyperselective, there is a risk. Pietro?
Yeah, I have another couple of questions. One is this patient had hemoperitoneum that eventually gave her a quite big pleural effusion. When do you think there is an indication to wash the hematoma away? Let's say after 1 week, that the patient is still in the hospital for surveillance before they go home to do a laparoscopy and evacuate the hematoma. Is there indication? When do you do it? When one should not do it?
Well, I don't remember the importance of the hemoperitoneum in these cases. I'm not sure that the pleural effusion is due to the hemoperitoneum, but I think that the pleural effusion is due to the subcapsular hematoma.
Right.
You see that? You have here, that is the cause. This large hematoma of the upper side of the liver is the cause of the pleural effusion. So for me, there is no indication to wash look at that, and look around the spleen. There is no liquid in the belly, no liquid. The hemoperitoneum is not very important, and that's why she didn't need any other procedure.
In fact, we did not do it.
Of course.
Now, the radiologist felt that this liver was bigger than normal, which would go with the steatosis, but they also thought that the spleen was bigger.
No,
and there are a few diseases with big spleen and adenomas that can be diagnosed with a biopsy, like a glycogen storage disease. And this was why the biopsy was raised, the question.
Okay. But what will, it will not change anything upon, what is do you think that she has some of, well, even if there is an hepatopathy, it will not change the project of surgery.
So maybe that you would do the portal embolization because we felt that this patient needed a right hepatectomy. That maybe if we wait, she will need less than a right hepatectomy.
You see, when the subcapsular hematoma is resorbing, and you'll see that maybe a right hepatectomy will not be necessary. Very often, when you operate, you have a very small part which is adenoma and some part with again an hematoma. But look at that. I don't see a very large adenoma here in the right part. I don't see. Where is it? There is one here, maybe. This is, look here, very few. It's not large. The hematoma is very large, but you'll see maybe it will not be necessary to do a right hepatectomy after. This is hematoma. This is liquid. Look at that.
Yes, but on the part on the the hematoma was measured by the radiologist at 16 centimeters. So quite big, nonetheless.
Yes, quite big, but it will regress. It will regress. In 2 months, it's half the size.
She has other two lesions, one in the left lobe and one at the point of segment 5. So would you recommend to do all resection of all adenomas at that time?
You know, this one here in the left lobe could be resected on the same in the same situation. Here you have the biggest. This one on the lower side. It has to be. Look at that. This one should be resected next to the gallbladder. This one is quite more dangerous. Yes, it is.
Right. So we will embolize both adenomas now and wait.
Yes, I
Bye.